Hello, everybody, and welcome to our TIF Talk. Thank you for joining us. I'm Andrea Millers with Endogastric Solutions, and very excited today to have our special guest, Dr. Kamran Ayub. Dr. Ayub, thank you for being here this evening.
It's my pleasure. Thank you for inviting me.
Of course. And we also have Wendy Profit from Endogastric Solutions. And as a reminder, if you are watching, please feel free, to mention where you're watching from so we can say hello. And then B, if you have any questions for Dr. Ayub, please go ahead and type the question into the chat section, and we will do our best to answer any questions. Before we start, Dr. Ayub, I'd like to give a little introduction and bio of Dr. Ayub. He earned his medical degree from Khyber Medical College in Peshawar, Pakistan, and he completed his internal medicine residency at Greater Baltimore Medical Center, where he served as chief resident. His fellowship in gastroenterology and advanced endoscopy was completed at Baylor College of Medicine in Houston. Dr. Ayub specializes in diseases of the pancreas, bile duct, esophagus, including gastroesophageal reflux and Barrett's esophagus, and cancers of the digestive tract. He has a passion for teaching, research, and innovation in the fields of advanced interventional endoscopy, and he holds several patents for novel endoscopic technologies. He has trained numerous doctors in advanced endoscopy and has written and spoken extensively on these topics at national and international meetings. He currently serves as director of the Center for Advanced Endoscopy at Silver Cross Hospital, is the president of the Illinois Endoscopy Society, and is medical director of Oak Lawn Endoscopy. He practices in Downers Grove, New Lenox, Oak Lawn, and Joliet, Illinois, and has been performing the TIF procedure for reflux since 2009. Thank you again, Dr. Ayub, for being here. We're very excited to talk to you today.
You're most welcome. As you know, reflux disease, disease of esophagus is one of my passions. So I'm always excited to be here. Thank you for inviting me.
Fantastic. Thank you. We'll go ahead and start the program today. We usually start off by discussing what is GERD. What could patients potentially feel if they were suffering from GERD or acid reflux?
So GERD, or gastroesophageal reflux disease, as the name indicates, entails reflux of gastric contents, especially gastric acid, into the esophagus. In a normal person, there is a junction between esophagus and stomach called lower esophageal sphincter, which is normally closed. When we eat food, it opens, allows for food to pass through and closes again, such that the stomach contents do not reflux into the esophagus. In patients with GERD or reflux disease, there's reflux of gastric contents into the esophagus. The most malicious of those contents is stomach acid. As you all know, stomach produces hydrochloric acid. The pH in stomach can be very acidic, usually 2 or even lower. pH in esophagus needs to be above 5 typically, close to normal of 7, between 5 and 7. When there is reflux of stomach contents or stomach acid into the esophagus, it causes irritation in the esophagus and leads to symptoms. The common symptom being heartburn, but they can also get spasm of the esophagus with chest pain, regurgitation of food, difficulty swallowing, and can get other symptoms like cough, asthma, breathing difficulties, etc. So that would be gastroesophageal reflux disease common symptoms.
Perfect. Thank you for explaining that. One thing that I know that you specialize in is, the progression of reflux and GERD. One of the questions we often get from patients is, what happens if I don't treat my GERD or if I just stay on my medication? So maybe you can discuss that a little bit.
Yeah, so the natural history of untreated GERD is pretty ugly, and it can end with a life-threatening cancer called carcinoma of esophagus. Gastroesophageal reflux disease leads to, as I mentioned, irritation of the lining of esophagus because esophagus lining is not made to deal with acid. Chronic reflux leads to ulcers, irritation in the lower esophagus that can cause narrowing or strictures down the road, bleeding from those ulcers, or can lead to change in lining of esophagus to an abnormal type lining called Barrett's esophagus. Barrett's esophagus basically is an unstable condition which can progress to cancer with 5% progression to carcinoma esophagus over 10 years. Uh, Carcinoma esophagus, unfortunately, is the one of the most lethal cancers known to mankind. So compare it to carcinoma of colon, for example, about 150,000 new cases of colon cancer every year in the United States, about 30 to 35,000 deaths in the United States. Compare it to carcinoma esophagus, between 35 to 40,000 new cases every year and close to 34,000 deaths every year. So it's an extremely lethal cancer. 5-year survival in a slightly advanced stage 2 or more advanced disease is less than 5%. 5-year survival for carcinoma colon at similar stage is 85 to 90%. Uh, Carcinoma esophagus and Barrett's esophagus are becoming more and more common. Over the last 3 decades, cancer of esophagus is most rapidly rising cancer in the United States. There's six-fold or 600% increase in incidence. So we need to take this cancer and the condition reflux disease very seriously.
Thank you for that. Can you talk about kind of the not progression, but the different types of treatment options? Like what are the initial things that patients should do if they start feeling, you know, the reflux and the continuous reflux and or refractory reflux if they're taking medication? So, you know, the lifestyle changes, the medications, and then so on and so forth.
So we are going through a paradigm shift in the treatment of reflux disease. There's a new paradigm now. We used to treat them with medicines, and only in the last 2 decades, we realized that long-term use of these medications have some serious side effects. I'll come back to that. But going back to treatment, the first treatment we start with is lifestyle modification. That includes trying to avoid eating heavy, fatty meals, spicy meals, especially close to bedtime. We like the patients to eat at least 3 to 4 hours before going to bed. So give the stomach chance to empty that food and there's less food and acid to reflux. Also, weight loss is a big part of the management in our country today. Obesity and weight problem is become endemic. Close to half my patients, if not more, with reflux disease are either obese or at least overweight. So weight reduction, if possible, is very, very important. Other risk factors, smoking, alcohol, chocolate, anything that you enjoy in life typically is refluxogenic. So you need to avoid those. Coffee can also cause reflux. So coffee we recommend drink in the daytime and in moderation, 1 or 2 cups a day, mostly in the morning, not in the evening or afternoon time, uh, etc. So we have dietary modification, weight reduction, and then we move on to avoiding any risk factors like smoking, alcohol consumption. Uh, then we go to medication. Medicines are divided into 3 major categories. There is the antacids like Tums, Gaviscon, Maalox, etc. Those are antacids that you drink and get immediate neutralization of acid in the esophagus. But once that antacid reaches the stomach, it causes rebound hypersecretion of acid. So while Tums might cause improvement in symptoms immediately, an hour or two later, symptoms come back with a vengeance because stomach secretes more acid when it smells alkali in the stomach. uh, the other class of drugs is an older class called H2 blockers. Those includes ranitidine, famotidine, or Pepsid, ranitidine, Tegamet, and Zentek. Zentek, many of the versions have been pulled from the market by FDA because there was some carcinogen in the material, not the drug itself, but the way it was stored and kept. So the H2 receptor blockers reduce gastric acid output, but for reflux disease, most patients require very high doses and was not very effective in eradicating endoscopic stigmata of reflux, including the ulcers, erosions, and none of the studies have proven beyond doubt that it prevented progression to cancer, to Barrett's esophagus and cancer. So we moved on to, in the late 80s, proton pump inhibitors. Proton pump inhibitors is very effective drugs for eradicating gastric acid. There is several different drugs, including omeprazole or Prilosec, lansoprazole or Prevacid. There is a few other ones, including Nexium and uh, another newer version that just came out. All of those drugs, unfortunately, have issues over the long term. We found out that over the long term, these drugs can cause dementia, can cause kidney damage. They do have direct effect on the kidneys and reduces our immunity because the stomach acid is gone almost completely. These patients can get gastroenteritis, Clostridium difficile type infections, and other infections like traveler's diarrhea. Incidence is much higher if you're taking these drugs. So those drugs, as I mentioned, over the last decade or two, are going out of fashion for long-term use. There is a paradigm shift towards anatomic correction. That's where TIF, Nissen fundoplication, and many other modalities come in.
Perfect. Thank you for that. I do see quite a few questions that are popping up on Facebook. So before we continue on, I'm going to go ahead and let Wendy ask some of the questions that have popped up. Wendy?
Excellent. Thank you. Well, I have a name twin. I think this might be a first. We have a Wendy who is actually asking if GERD causes allergy symptoms.
Good question. So, to my knowledge, GERD in and of itself does not cause allergies, but its symptoms can be similar. Asthma or bronchospasm due to gastric acid can be similar to allergic asthma due to pollens or other allergens. So, it can cause symptoms similar to allergy. Cough, sneezing, nasal running nose, etc., can also occur due to irritation from reflux of acid. So some of the GERD symptoms are similar to symptoms of allergy, but it in and of itself does not cause allergy.
And Jason asked, this might be along the lines of what you're mentioning here. Can you talk about silent GERD, and is it more dangerous than regular GERD?
Good question. So we are recognizing more and more silent GERD over the past 2 decades. Many experts, gastroenterologists in the country, are recommending that just like we have a screening colonoscopy at age 50, now at age 45, we should at the same time have a screening upper endoscopy, especially if there was any history of heartburn during their lifetime, family history of carcinoma esophagus or Barrett's esophagus or anything. But most experts are recommending a screening upper endoscopy in everyone. The reason being, when we go in, we find either Barrett's esophagus or reflux changes, including erosions, ulcers, rings or Schatzki's ring, we call it. All those are complications of chronic acid reflux without any symptoms. The hypothesis is that the nerve endings in lower esophagus that are very sensitive to gastric acid, in many people, after recurrent reflux, chronic reflux episodes, the nerve endings are either destroyed or they become immune to acid, so they do not perceive acid as a problem. So these patients, many of my Barrett's esophagus patients tell me, but doctor, I don't have any symptoms. And I find Barrett's or Barrett's that has dysplasia one step from cancer. I tell them, no, you have had chronic reflux, your valve is very loose. If you were to do pH monitoring, ambulatory pH monitoring on these patients, they have severe reflux, but no symptoms. So silent reflux is common. I encourage my patients to undergo screening upper endoscopy at the time of screening colonoscopy, most of my patients.
Excellent. Yeah, sleep, just having a little extra nap, is not a bad
Exactly.
thing, right?
It takes a few minutes extra.
Okay, I have one more, Andrea, and then I'll toss it back to you for a bit. Haley is asking, she is pregnant and has terrible GERD. Although I'm told it will go away, is there a difference between pregnancy-induced GERD and the more typical GERD patient that you see?
Good question. So pregnancy is a highly refluxogenic condition. Uh, Pregnancy, the hormones, progesterone part and some of the other placental hormones causes relaxation of lower esophageal sphincter, making you more liable to reflux. Also causes spasm of pylorus and a condition called gastroparesis, where your stomach does not empty well. So food sits in the stomach for a long time. Gastric acid sits in the stomach for a long, long time with the loose valve, which obviously leads to reflux. At the same time, as the pregnancy advances, as the fetus grows, intra-abdominal pressure rises remarkably. So abdomen has a positive pressure normally, chest is negative pressure. Now, with the fetus, the intra-abdominal pressure is rising, it's compressing on the stomach, and the valve is loose, relaxed because of progesterone and other placental hormones, uh, uh, different placental hormones. There is a high tendency towards reflux in pregnancy. We try to treat them with a proton pump inhibitors during pregnancy. Most of the patients, once they lose the pregnancy weight after delivery, reflux goes away. But some patients, reflux persists, and those are the ones who need to seek medical advice.
Excellent. Thank you. All right, Andrea, we'll toss it back to you.
Thank you, Wendy. So, Dr. Ayub, can you talk about the different diagnostic testing that a patient would undergo to determine whether or not they have GERD A and B could be a potential candidate for one of these endoscopic procedures that we're going to talk about today?
So the first test, basic test that we do in patients with chronic reflux type symptoms or any upper GI symptoms is upper endoscopy. At the time of endoscopy, gastroenterologists look at lower esophagus very carefully, the junction between esophagus and stomach. If there is any evidence of irritation, inflammation, ulcers, or anything else, nodules, anything ugly, we biopsy. And biopsy then tells you if there is inflammation, irritation, or if there is progression to a condition called Barrett's esophagus, the precancerous condition, or God forbid, there is early cancer of the esophagus. So upper endoscopy is the basic mainstay of diagnosis of reflux disease. Once we have done that, if a patient has Barrett's esophagus, we treat that and then talk about endoscopic or surgical management. Nowadays, again, as I mentioned, there is a paradigm shift. So endoscopic management has really, really advanced. Surgeons, physicians, all of them have embraced TIF, hence this talk today. I am performing probably 5 times more TIF this year than I did 5 years ago. Even American Society of Surgeons is highly recommending it. So then we talk about that. If patient does not have Barrett's, just reflux, then most of the time insurance company requires that we document acid reflux by a test called Bravo ambulatory pH monitoring. In this test, at the time of endoscopy, we place a capsule in the lower third of esophagus, about 6 centimeters above its junction with the stomach. And that capsule measures the pH in esophagus for 2 or 4 days. We typically do 4-day test nowadays. And that test is recorded on a small receiver that patient wears on their belt. Then once they bring back the receiver 4 days later, we are able to tell if this patient's acid reflux episodes are qualify as gastroesophageal reflux disease or are within the normal range. Those are abnormal. We go to insurance, get the approval, and move ahead with some anti-reflux procedure.
Perfect, thank you. Well, let's talk about the TIF procedure. Do you want to go ahead and explain what is the TIF procedure and how does it work?
So TIF procedure, or trans-endoscopic incisionless fundoplication, as the name indicates, is an incisionless procedure where we go in and locate or create a junction, a valve, donut shape valve at the junction of esophagus and stomach. So the normal people have a valve between esophagus and stomach, which is nice and tight. If intra-abdominal pressure rises, it actually closes further because the valve overhangs into the stomach. In patients with reflux, you don't have that type of mechanism. That area, the junction between esophagus and stomach, is wide open. So what we do is we go in, pull the GE junction area and put sutures across it to create a valve like the natural valve. It mimics the natural valve, and it mimics the valve created in the past by surgeons using a technique called Nissen fundoplication. Nissen fundoplication has been an established anti-reflux surgical procedure for years, decades, now gone out of fashion because we can do the same thing endoscopically. So even if surgeons are doing hiatal hernia repair, they want the gastroenterologist to do this incisionless fundoplication. It's just as good as the surgical fundoplication, but does not require incision, suturing from outside. There's no scarring and does not create a kind of permanent problem. So if you want, you can revise TIF procedure down the road. You can do other procedures, surgical procedures on that GE junction. But once you have the surgical fundoplication, it creates scarring, adhesion, such that future procedures become dangerous and difficult.
Thank you. I did see a question that came up in regards to side effects from anti-reflux procedures. Maybe you can talk about the differences between, per se, the Nissen procedure versus the TIF procedure, and are there differences in outcomes and side effects?
So Nissen fundoplication is done surgically. Surgeon makes keyholes and either uses a laparoscope or a robot to perform the fundoplication. They go in from outside, invaginate the junction between esophagus and stomach into the stomach, and then suture from outside. We, with Nissen fundoplication, go into the stomach, retrovert the endoscope, pull down the GE junction from inside, and put stitches across it. There is no incision involved. Whenever there is incision, there is risk of bleeding and infection. So those risks are almost eradicated with it. There is still very, very small, minuscule risk, but pretty much close to zero. The Nissen fundoplication performed by surgeon from outside, surgeons can over-tighten the GE junction. The commonest side effect of Nissen fundoplication is bloating, inability to burp, inability to vomit, because patient's junction becomes too tight. They are suturing from outside, so you can imagine they can over-tighten. With us, we are going through the esophagus into the stomach. So we are tightening and creating a valve around the endoscope and around the esophagus, the TIF device that we use to create this valve. So we cannot over tighten. That's why bloating, inability to belch, inability to vomit are extremely uncommon or extremely rare with TIF procedure. But about 20 to 30% of Nissen fundoplication have bloating, tummy feels swollen because they cannot belch. All of us unintentionally, unknowingly keep belching, passing gas up. That does not happen. It has to go only downwards. So they get bloated, they have inability to belch, inability to vomit, etc. Much more common. Infections, other wound adhesions are more common. In the long run, TIF can become loose and Nissen fundoplication can become loose. If TIF becomes loose, we can go in and do another TIF, or surgeon can go and do Nissen fundoplication, no harm done, because there's no scarring outside, no incision. Nissen fundoplication similarly becomes loose after 5-7 years. To do a redo Nissen is extremely dangerous and difficult procedure. Only very few surgeons perform that procedure in tertiary centers, so it's not an easy procedure to perform. We can, however, perform TIF on previous nations. I've done several of those, and that seems to work well. So those would be the main differences. Obviously, surgeons are much more expensive than gastroenterologists, so TIF would be cheaper on insurance and copay deductible as well compared to surgical procedure.
Right, thank you. And you had mentioned that you're doing 5 times more, there's this paradigm shift, 5 times more TIF procedures than you did in the past. I would suspect that has a lot to do with how your patients are doing and the outcomes of your patients. Can you talk to us a little bit about how your patients are doing after the TIF procedure? And then maybe we can go into recovery and what can they expect post-TIF procedure.
So patients tend to do very well. Actually, 5 and 10 years ago, I went to these good surgeons and said that, hey, we have this procedure TIF that some centers are doing with the surgeon. So you go repair a hiatal hernia, put the stomach back into the tummy from the chest if they have a hiatal hernia, meaning their stomach is in the, and we do the TIF. It's called combined TIF, works very well. They said, oh, not interested. When I'm doing hiatal hernia, why shouldn't I just do the fundoplication, Nissen fundoplication at the same time? Your TIF is similar. Why do 2 different people involved? Now, over the last few years, those same surgeons came back to me, said, oh, we were at American College of Surgeons meeting, we were at Digestive Disease Week, we saw this paper, Dr. Hunter talked about it, Dr. So-and-so, experts spoke about it, presented their experience. It seems that this combined TIF is less invasive than surgical fundoplication, has less side effects, and the results are just as good, if not better. So we want to team up with you and do that. And that's how my volumes increased dramatically over the last few years. Some of the top surgeons who had refused to work with me before now came back to me because they saw the data, they saw the evidence presented at scientific conferences. These patients tend to do very well. They do have some pain initially. They do have to stay on liquid diet for a few days, just like surgical fundoplication, sometimes a week or 2, but they do very well in the long term. And side effects, long-term side effects are rare.
Fantastic. Thank you so much. That's so great to hear. I see a couple of questions pop up, so I'm going to pass it over to Wendy to get some questions through.
Thanks, Dr. Ayub. We're getting a lot of comments just thanking you for the excellent information that you're providing. We've had several questions about hiatal hernia. I think you've covered a good bit of that. We may circle back at the end if time allows. One thing that John is asking is, are your TIF patients happy to be off of their PPIs?
Yes. So some of the patients have side effects from PPIs and others. Some of the patients have side effects, so they don't want it. Others don't like the expense. But the silent problem here that they are realizing now is over the long term, they can get kidney damage, they can develop dementia. This is over 5-10 years. As you know, GERD, once you get reflux, it's a lifelong disease. You're taking those medicines for a lifetime. So over 5 to 10 years and longer, you can develop dementia, you can develop kidney damage, you have issues with the heart drugs, some interactions with Plavix, some of the antiplatelet drugs that they take for the heart, and you have issues with gastroenteritis, Clostridium difficile diarrhea, and other infections. So those are the main benefits, that you avoid those long-term complications. It's one-time expense versus paying for the drug month after month, week after week. And some patients have side effects with proton pump inhibitors that we see are diarrhea and headache. So those side effects, again, they are able to avoid. They're much happier. Typically, 85 to 90% of patients are off proton pump inhibitor over the next 3 to 5 years, the studies have shown. So that's a very high, good success rate for this disease, which has not been easy to treat in the past.
Good, thank you. And did I read also, maybe for us girls who are over that hill now, that osteopenia is associated potentially too?
So postmenopausal women are at high risk of developing thinning of the bone or osteopenia. Vitamin D that causes deposition of calcium and phosphorus into the bones is so-called fat-soluble vitamin, and it requires stomach acid for absorption. So when we eradicate stomach acid, these people have relative deficiency of vitamin A, D, E, and K, four of the fat-soluble vitamins, and vitamin D deficiency leads to tendency towards thinning of the bones, weaker bones. Women, postmenopausal women, once the estrogen progesterone is gone, are at risk of thinning of the bones. A woman typically don't die of heart attack. If you go to old people home or nursing homes, 90% of the residents are women. Men are long gone. And those 90% of women, one of the commonest cause of death is fracture, either hip fracture or spinal issue, spinal prolapse fracture. And then they develop thromboembolism after that or other complication from the fractures and die. So it is very common to have osteopenia, thinning of the bone in women after menopause, and proton pump inhibitors will accelerate that, accentuate that thinning of bone or osteopenia. So yes, in my patients who are on proton pump inhibitor, do not want to or cannot undergo TIF for some reason, I do bone densitometry, make sure their bone density is okay. Otherwise, we have to give them some of the stronger drugs preparations to get vitamin D working and improve their bone density.
Very good. Thank you. Andrew says, my gastroenterologist told me my hiatal hernia wasn't very large and that I should just stay on PPIs. I'm still having symptoms that are uncomfortable, and I'm questioning if my doctor is properly diagnosing me. Is it possible my doctor has missed something and perhaps my hernia is more significant?
So there is two separate issues here. One is gastroesophageal reflux disease, other is hiatal hernia. Hiatal hernia means that part of your stomach, be it small part, 1 centimeter or 10 centimeter large area, is above the diaphragm in the chest. It has herniated into the chest. Hiatal hernia predisposes to reflux because the diaphragm and below diaphragm, you are in a different pressure zone. Once you come into the negative pressure, the stomach, that part of stomach, any acid that it secretes is freely flowing back into the esophagus. So it does predispose to the reflux, but that's not the only cause of reflux. You can have no hiatal hernia and reflux disease. So I think that the reflux symptoms, if they're present, she should have an endoscopy and biopsies, and if needed, ambulatory pH monitoring to see if she actually has reflux or not. Then she should get it treated, be it with proton pump inhibitors. But as I mentioned, in many areas, there is a paradigm shift towards anatomical correction rather than giving lifelong drugs or medication, especially in women, postmenopausal women. As you mentioned, there is the osteopenia issue. So we like to treat them.
Thank you. Christopher is asking, at what point would you recommend having a TIF done? I've been on PPIs for a while and they work for the most part.
Yes, so that's the difficult part. PPIs are very effective. They eradicate the stomach acid, so very good for eradicating or treating symptoms of reflux disease. About 80 to 90% of patients do very well symptomatically with PPIs. But there is the cost, there is the lifelong use. You have to use it whenever you stop using, symptoms come back. But most worst of all, long-term use can lead to side effects that we mentioned already, including dementia, kidney damage, cardiac drug interactions, bone thinning, and gastrointestinal infection, to name a few. So in the long run, if you are requiring proton pump inhibitors such that when you stop taking it, you have reflux symptoms, I think that should see a gastroenterologist who specializes in diseases of esophagus and see what their opinion is. Many of them are recommending TIF now more and more. It's basically expanding. So most areas in country, TIF is being recommended as the first line treatment if you require long-term proton pump inhibitors.
Very good. Thank you. One last one, Andrea, and we'll jump back over to you, is asking if TIF can be, let's see, can it be reconstructed back, or is this forever? I guess we can make the assumption that she's asking if it can maybe be taken down. And then she asks also, is there another way other than TIF surgery?
So TIF, number one, once it's performed, uh, once the scarring has taken place, it cannot be reversed. But if the junction becomes too tight, we can go and expand the junction. We call it balloon dilation. A dilation can be performed if they have symptoms from TIF, which is extremely, extremely rare and unlikely. Number two, TIF can be re-performed. So if patient has TIF, done very well for 5 years, but now TIF or GE junction is becoming loose again, we can do re-perform TIF. It takes only 30 minutes or so to perform the TIF procedure. So we can redo this procedure. Uh, I would not see any major reason to undo the TIF once you have performed it, unless patient was having extreme symptoms. As I mentioned, those are extremely uncommon, extremely rare in my practice, because you cannot over tighten the GE junction. You are tightening and performing this suturing, creating a valve, 270-degree valve, over the esophagus device, over the endoscope.
Perfect.
Excellent. Thanks, Andrea. Back to you.
Thank you so much. So, Dr. Ayub, kind of closing out, the evening, we always like to ask if there is any words of advice that you would give patients that have been or are suffering from reflux or GERD today. What would your advice be?
Sorry, before I go back, I forgot to answer the second part of your question, Andrea. There are other treatments available. There is reflux mucosectomy, and there is strata. Those are both relatively new and have a more limited application. So TIF is the mainstay. Anti-reflux mucosectomy is not covered by insurance or Medicare as a procedure. Strata is covered by some, but again, it's for very mild form of reflux, limited number of patients. So most of the patients is TIF, but there are some other weapons in our armamentarium against reflux to treat that. Those have much less applications. Going on to the advice to my patients, I think that the key, my feeling is that the GERD epidemic in our nation is a direct result of increasing BMI or increase in weight. Obesity has become an epidemic. About 12 or 13 years ago, obesity overtook smoking as number one preventable cause of death in this country. So my first advice is that if you're overweight, please try and reduce weight, diet and exercise. Try and avoid fatty meals, high calorie meals, sweet things to try and lose weight. Number two, lifestyle modification is very important. Number three, long-term PPIs are going out of fashion. Within, I think, 10 years, most places will not be prescribing long-term proton pump inhibitors. See someone who has interest and expertise in reflux disease and who offers endoscopic anti-reflux treatment like TIF. And more likely than not, they will recommend TIF as a treatment if you're a suitable candidate. If somebody has triple vessel heart disease or severe COPD and is not a candidate for TIF, that's a different situation. But most of the younger or elderly who are in good health, TIF is a relatively less invasive procedure, much less invasive than surgery, for example. So it can be performed on most patients. So it's best to see an expert and talk about your reflux symptoms to those people, because reflux, even though it appears benign, it can lead to carcinoma of esophagus, which is an extremely lethal cancer. And we are seeing a huge rise in the incidence of carcinoma esophagus over the past 2 decades.
Yeah, I like what you mentioned earlier in our talk about recommending people to get their upper GI, scheduling their colonoscopy as well, for fear of that, silent reflux possibly going on.
All the gastroenterologists, especially experts in esophagus, Barrett's esophagus, strongly recommend that. And it's basically, I think, will become American Cancer Society guidelines soon.
Yeah, right. Well, Dr. Ayub, we can't thank you enough for joining us this evening. If you are in you're not really in Chicagoland area, right? You're in if I can remember correctly, south of that.
Yeah, western suburbs of Chicago.
Thank you. Western suburbs of Chicago. You can find Dr. Ayub. But if you are not and you are looking for a TIF trained physician, you can go onto gerdhelp.com, and we do have a physician finder there. You can just put in your state and or your zip code and you'll be able to find a physician near you. In addition to that, we also have a mobile app. It's called GERD Help. You can just search for it on your mobile app store. And there's lots of great information on there. We have all these TIF Talks on there. You can track your symptoms. You can track kind of the foods that you're eating or the triggers for your GERD. Then you can potentially bring that into your physician and let them know what's been going on. So any last parting words of wisdom, Dr. Ayub, before I go? It looks like Wendy has something to say, so I'm going to pass it.
A quick sales pitch that my website is called refluxchicago.com. So, and it does have a lot of information about reflux disease and TIF, including a video of TIF procedure. So feel free to log on to refluxchicago.com.
Beautiful. Thank you. Wendy, it looks like you had something to say.
Yes, number one, I want to thank all of our viewers tonight. We had a lot of questions that we did not get to. However, if you tuned in a little bit late and posted a question that was not answered, that is because it was covered earlier in the program. So this program will be available on our Facebook page, and just want to make sure that everybody knows you can go back and watch it and your question was answered prior to you asking it. That's how fancy Dr. Ayub is. So thanks very much.
Fantastic. Yes. Dr. Ayub, thank you again. Wendy, thank you. And everybody watching, thanks for joining us. And we will catch you next time. So have a great evening. Thank you.
Thank you all.